Hello, I'm Dr. Jenny Andrus, and welcome to Joint Ventures. In this OSC original podcast, we take a look at recent medical news and headlines. We know medical news can be difficult to understand, and it's hard to know which sources you can trust. This podcast format gives us time to dive deep into the science, as well as the controversies. Our goal is to review the latest medical news and trends in a non-biased way and be a source you can trust with your health. If you are new to this podcast, welcome. We're so happy you tuned in. I'm an interventional pain management physician at Orthopedic and Spine Center in Newport News, Virginia. Just like all of you, my life and my medical practice was upturned 5 years ago with the COVID-19 pandemic. And just when we thought we were getting done with it all, we started seeing patients with long-term pain complaints following COVID infection. Is the pain related to COVID? Related to all the detrimental effects of the lockdowns like weight gain and depression? Or not related at all? Everything COVID-related seems to be cloaked in political biases, which makes it really difficult to know which sources of information are trustworthy. All right, so let's dig through this concept of long COVID syndrome from a medical standpoint and leave all the biases to the politicians. Recent clinical updates in the diagnosis and management of long COVID has shed more light on this process. What is long COVID anyway, and how is a patient or a clinician supposed to know if their symptoms are due to long COVID? And if so, what, if anything, can we do about it? Long COVID is defined as a constellation of symptoms persisting for over 3 months after acute COVID-19 infection. It can affect multiple organ systems and lead to impaired function. The symptoms are varied and sometimes ill-defined. Fatigue is common. Pulmonary symptoms, including shortness of breath with activity, abnormal breath patterns, chest pain and sore throat, neurocognitive dysfunction or brain fog, anxiety, depression, and poor sleep are also common complaints. Orthostatic intolerance, which is where a person will get dizzy or lightheaded with being upright, loss of smell, and vertigo may occur. Allergic type symptoms and sensitivities develop. Joint pain and muscle pain, as well as muscle weakness and wasting, are nonspecific but common complaints. This, of course, is something that I look at in my practice when patients just aren't responding to normal treatment for pain. Determining how many people develop long COVID has been extremely difficult. COVID infection is so common and it overlaps with other viral illnesses, so most people never present to a doctor or have a confirmatory test. Just knowing who had the infection and when is difficult. Most studies looking at symptoms did not separate out minor from severe symptoms, so that patients with very minor symptoms are still lumped in calculations of prevalence. 2 meta-analyses concluded that long COVID occurs in 45 and 57% of people after infection. Those numbers are simply not reliable. Additionally, people who have organ damage as a result of COVID, specifically lung damage or fibrosis, and have persistent problems related to that damage itself, are put in the same category as people who have symptoms with no objective evidence of organ damage. That absolutely makes no sense to me. So, for instance, if a person has a severe infection and develops sepsis and is hospitalized with organ failure, and then has persistent dysfunction in that organ, you wouldn't necessarily call that ongoing organ dysfunction long sepsis. When most people think of long COVID, they're thinking of a constellation of symptoms that are not explained by other problems without clear organ damage. Now, there are parallels between long COVID and other post-acute infection syndromes, including those of other coronaviruses, including Epstein-Barr virus and West Nile virus. So how might long COVID infection produce these long-term symptoms? We don't have a definite cause, but ideas include accumulation of the virus in tissues with direct damage. This could also result in reactivation of other viruses. The second concept is that immunoinflammatory mechanisms form a dysregulated immune response. The third idea, which has gained a lot of traction, is endothelial inflammation and thrombosis. This is the blood clotting which resulted in so much morbidity and mortality with COVID-19 infections. Other mechanisms to consider are altered gut microbiomes, the natural bacteria of the gut, which are necessary for so many aspects of health. Neuroinflammation and microthrombus formation in the central nervous system may account for the persistent neurological dysfunction resulting in neurocognitive disorders, psychiatric disorders, or chronic fatigue. In the peripheral nervous system, vascular changes and oxidative stress may result in pain. Epidemiological studies have identified some factors that seem to be associated with developing long COVID. Women, aged 35 to 50, and those with socioeconomic disadvantage self-report more symptoms. People with type 2 diabetes, asthma, lung disease, heart failure, and chronic kidney disease also were more likely to report long COVID symptoms. Obesity and having had a more severe COVID infection were also associated with long COVID. Since hospitalization from COVID was always uncommon, 2% in 2020, 1% in 2021, and now even much rarer, most people with long COVID have relatively mild to moderate COVID infection. Most patients will describe a viral illness, although there are cases of long COVID in people who had asymptomatic infection. People who were admitted or seen at the hospital due to respiratory symptoms were more likely to go on to develop persistent respiratory symptoms such as shortness of breath. People might even describe partial or even complete but temporary recovery after infection before they develop these symptoms. A striking and concerning characteristic of long COVID is the functional impairment, with many patients stopping work. So how is this diagnosed? There is no test, no biomarker to tell you that you have it or you don't. Diagnosis is going to have to be a diagnosis of exclusion. That means that other culprits are excluded, like for instance, with persistent shortness of breath, there's no evidence of ongoing lung disease, no pulmonary function testing problems, no evidence of cardiac disease on stress tests to explain the symptoms. Treatment is pretty much just supportive. There is some data that exercise should be graded and paced. Respiratory symptoms may be treated with breathing control exercises. Orthostatic intolerance can be treated with fluids, electrolytes, compressions, garments, and sometimes medicines. Neurocognitive dysfunction or brain fog is treated with psychological support, including pacing and energy conservation. Pain is treated with mobilization, NSAIDs, neuropathic agents, and endurance training. The course of long COVID is also frustratingly variable. Some people experience apparent recovery and then they relapse. Many of people with long COVID have pre-existing conditions like allergies, ADHD, musculoskeletal pain, diabetes, mental health disorders, headaches, chronic fatigue. When these comorbidities are present, how do we know if COVID caused, exacerbated, or is unrelated to the long-lasting symptoms? If you were listening to this, you were old enough to remember the lockdowns. Everyone gained weight, me too, got lonely and anxious and depressed. People lost their jobs and their savings. It takes years to dig out those holes. So how do we know if the subjective symptoms of pain and worsened mental health are not the result of the socioeconomics of COVID as opposed to a post-viral syndrome? As of now, we don't. Most authors now are looking at long COVID as a more heterogeneous group. Think of splitting into groups, those with the sequela of acute infection, like loss of smell, those with severe disease and prolonged hospitalization, who have complications that are commonly seen after long ICU stays, then those with the pulmonary fibrosis, then those people with the orthostatic symptoms, and then those with the more chronic fatigue, neurocognitive, or painful type syndrome. It seems clear to me that these are not the same problem, and they probably don't have the same cause. Treatment may overlap, of course, but we really need to understand the distinctions between these groups to better treat them. There's an old sitcom that my husband loves to watch reruns of all the time, and one of the characters works for a drug manufacturer. And the joke is that they made up a drug, and then they made up a disorder to treat the drug. And when I was telling him about this research, he reminded me of that episode, and that gave me some pause, okay? I don't want to convey that this is a made-up disorder. There are clearly people I know in and outside of my professional life who still deal with the ramifications of a COVID infection. But also, when you have vague symptoms, which can be explained by many things, pinning them on a post-viral syndrome might actually have a negative impact on patients. I certainly do not want to diagnose people with a long-term illness that they don't actually have. The take-home point is that this is a real problem, but is very poorly defined and in most cases difficult to diagnose. Obviously, preventing viral outbreaks in the future, of course, will be the key to preventing these post-viral syndromes. Okay, that was a bit more heavy than our normal ones. Thank you for hanging in there with me for this episode. Please consider subscribing to this podcast. We don't want you to miss out on any of our further discussions. Thank you again. Wishing you good health, and see you soon. Bye-bye.
At Orthopedic and Spine Center, we're dedicated to providing the highest quality treatment using the most advanced technology available. Our fellowship-trained spine and interventional pain management physicians specialize in diagnosing painful conditions and offer minimally invasive interventions to complex spine surgeries. Our pain psychologist helps patients understand and reduce stress from chronic pain conditions. Our experienced physicians get you back to doing what you love. Call today for an appointment. Experience excellence at Orthopedic and Spine Center.